Let's start with a 20-second awareness reset, a practice known to boost retention by up to 20%. Close your eyes, breathe in slowly, and out. Now, recall the last time you needed to act fast in a clinical setting, or imagine you're the only pharmacist on duty. How would you handle a UTI case with a resistant organism? This emotional anchor boosts attention and primes the brain for deep learning. All right, let's dive in. So you're faced with a tough call. What do you give for uncomplicated cystitis when your patient has a sulfa allergy and maybe a creatinine clearance of 25?
Yeah, that's a tricky one right off the bat.
And then what if it's a man? Maybe flank pain, fever, positive urine culture?
Completely different scenario.
Right. UTIs can seem simple, like really simple, until they're absolutely not. And they're all over the NAPLEX.
Oh, definitely. Expect to see them.
Today's deep dive walks through diagnosis, first-line agents, those really important renal considerations, drug resistance, and, well, testate traps.
Exactly.
This isn't just about knowing NIT, roflurantoin versus trimethoprim, sulfamethasol.
No, it's deeper than that.
It's about making the right call fast. Okay, let's unpack this then. Before we even get into specific treatments, maybe we should lay down the foundational understanding. What is a UTI, really?
That's the perfect place to start. Fundamentally, a UTI is microbial infiltration. Basically, bugs getting into the urinary tract, which should be sterile.
Sterile, right. So not just contamination from the sample collection.
Precisely. It's a real invasion. And we generally classify them by location. So you have lower urinary tract infections, that's cystitis.
Cystitis, good.
And then upper urinary tract infections, which is pyelonephritis. That's the more serious one involving the kidneys.
Gotcha. So cystitis down low, pyelonephritis up high in the kidneys. How does that progression usually happen? Like, how does cystitis become pyelonephritis?
Well, cystitis usually starts with contamination around the urethra. Gut bacteria, uropathogens, they kind of set up shop there first.
Okay.
Then if those bacteria manage to ascend, like travel up the urinary tract to the kidneys, that's when you get pyelonephritis.
Okay. So it climbs up.
Exactly. And then there's another huge distinction we need to make right away. Uncomplicated versus complicated UTIs.
Yes. That one feels really important for treatment choices. What defines uncomplicated?
Uncomplicated UTIs, generally speaking, occur in women of childbearing age who have a structurally and neurologically normal urinary tract. Think standard infection, healthy system.
Okay, straightforward case. So complicated must be everything else.
Pretty much. Complicated UTIs happen in patients with some kind of functional or structural issue, maybe kidney stones, an indwelling catheter, diabetes affecting bladder function. Even being male puts you in the complicated category usually.
Right. Male UTIs are almost always complicated. And what about other risk factors? Who's more likely to get a UTI in general?
Well, age is a factor. Definitely sex women are much more prone anatomically. Pregnancy increases risk, diabetes too. Catheterization is a really big one. And vaginal intercourse is often cited.
Makes sense. And the culprit bacteria? Is it always E. coli?
Mostly, yeah. Escherichia coli or E. coli is the big one. It causes maybe 70 to 95% of uncomplicated UTIs. Huge percentage.
Wow.
But you also see others. Staphylococcus saprophyticus can show up, and enterococci are fairly common. Gram-positive isolates, too.
Okay, so we know what it is, who gets it, how do we actually confirm it? What are we looking for in the diagnosis?
Diagnosis really needs two things. The patient having symptoms plus a positive urinalysis and maybe a urine culture.
Okay, symptoms plus lab work. What does the urinalysis show us?
In the urinalysis, we're looking for key indicators. Pyuria is one that's having white blood cells, leukocytes in the urine, 10 or more per cubic millimeter. It shows inflammation.
Inflammation, right.
Yeah.
But not specific to UTI necessarily.
Correct. Not entirely specific, but a strong clue. The other big one is nitrate reduction. Some bacteria, including E. coli, Klebsiella, Proteus, even Staph and Pseudomonas, they convert nitrates, which are normally in urine, into nitrates.
So a positive nitrite test is a pretty good sign of those kinds of bacteria.
It's a helpful indicator, yes. Points towards certain common culprits.
What about the urine culture? Do we always need that?
Not always for acute, uncomplicated cystitis. If the symptoms and the urinalysis are pretty clear-cut, you might proceed without it.
Okay.
However, for complicated UTIs and definitely for acute pyelonephritis, a urine culture is strongly recommended. Essential, really.
Why essential for those cases?
Because you need to know exactly which bug you're dealing with and what it's susceptible to. Treatment is longer, potentially involves IV drugs, the stakes are higher. A positive culture is usually defined as 10 to the 5th colony-forming units per ml 105 CFU ml, from a clean midstream urine sample.
10 to the 5th CFU/ml.
Yeah.
Got it. Now, the symptoms themselves, how different are they for cystitis versus pyelonephritis? Are there, like, tricky presentations we should be aware of?
Good question. For cystitis, the lower tract stuff, you're typically looking at urinary urgency, frequency, dysuria, that painful urination, and maybe some suprapubic tenderness like low belly pain.
Classic bladder infection symptoms?
Exactly. Now, when it moves up to pyelonephritis, the upper tract, you often get those same bladder symptoms plus systemic signs. Think fever, flank pain, the pain in the side, or back nausea, sometimes vomiting. It feels much more like a whole body illness.
It makes sense. It's involving the kidneys. Any pitfalls in recognizing symptoms?
Definitely. Atypical presentations are key to watch for. Some groups, like patients with indwelling catheters or maybe certain neurologic disorders, they might not have those classic lower tract symptoms at all.
So what do they present with?
It can be more vague, maybe just flank pain or a new fever without an obvious source, sudden blood in the urine, or even just some pelvic discomfort. Recognizing these is really crucial because delaying diagnosis can lead to serious problems.
Okay, this next part is where I think things get really interesting and maybe a bit counterintuitive. Sometimes you find bacteria in the urine, like on a culture, but the patient feels totally fine. No symptoms? What's that called, and what do we do?
Ah, yes. You're talking about asymptomatic bacteriuria, or ASB.
ASB.
It's defined exactly as you said. Significant bacteria, usually that same 105 CFU/ml threshold, in a properly collected urine culture, but without any signs or symptoms of a UTI.
So bacteria are there, but no infection symptoms. Do we treat it? My instinct says yes, get rid of the bacteria.
That's the common instinct, but the guidelines generally say no. Screening for and treating ASB is actually not recommended for most people.
Really? Why not?
Well, studies show there's generally no clinical benefit in treating it in, say, non-pregnant women or men, and treating it unnecessarily definitely contributes to antimicrobial resistance, which is a huge problem we're trying to combat. So we avoid antibiotics unless there's a clear benefit.
Okay, avoid treatment for ASB generally. But are there exceptions? Times when we do treat it?
Yes. Absolutely critical exceptions. You should screen for and treat ASB in two main groups. Pregnant women.
Pregnant women, okay. That makes sense. Protect the baby.
Exactly. And the other group is individuals who are about to undergo invasive genitourinary tract procedures, like certain types of urinary tract surgeries. Treating ASB beforehand can reduce post-procedure complications.
Got it. Pregnant women and pre-GU procedure? What about patients with catheters? You mentioned them earlier. They often have bacteria, right?
Oh, absolutely. Bacteria is practically universal in patients with long-term catheters, and often it's multiple types of bacteria because the catheter is, well, a foreign body.
So if a catheterized patient has bacteria on culture, but no symptoms, still no treatment?
Correct. Still no treatment if they are asymptomatic, regardless of the colony count. Treating ASB in these patients doesn't prevent symptomatic infections down the line, it just breeds resistant bugs. It's a very common scenario and a frequent point of confusion.
Okay, that clarifies ASB. Let's switch gears to treatment for symptomatic infections. Starting with the most common scenario, uncomplicated cystitis in women. What are our go-to first-line options?
Right, for uncomplicated cystitis, the guidelines in the U.S. point to three main first-line agents.
Three main choices.
Okay. First is nitrofurantoin, nitrofurantoin, usually given as a 5-day course. It works by concentrating really highly in the bladder urine.
So it's like a targeted antiseptic for the bladder.
Exactly. But, and this is key, it doesn't penetrate well into kidney tissue. So it's great for cystitis, but not for pyelonephritis. And critically, it's contraindicated if the creatinine clearance is less than 30 ml/am. Remember that CRCL cutoff? Less than 30, no nitrofurantoin.
CRCL less than 30, avoid. Got it. What's option number 2?
Trimethoprim sulfamethazole, or TMPSMX, often called Bactrim or Septra. It's typically a shorter 3-day course.
3 days shorter. Any catches with TMPSMX?
The main one is resistance. If local E. coli resistance rates to TMPSMX are known to be high, say over 20%, you should probably avoid it empirically.
Over 20% resistance, be cautious.
Okay. And the third option?
The third one is fosfomycin trometamol. Fosfomycin. This one is unique because it's just a single 3-gram oral dose, one and done.
A single dose, that sounds convenient. It can be, and it has good activity against E. coli, even including some resistant strains like ESBL producers. That's a plus. But its activity against some other common UTI bacteria can be limited, so it's not a perfect solution for everything.
Okay, so nitrofurantoin, 5 days, watch CRCL. TMPSMX, 3 days, watch resistance, and fosfomycin, 1 dose. What if none of those work for a patient? Allergies, resistance. What are the alternatives?
Good question. If first line isn't an option, we look at alternatives. Fluoroquinolones like ciprofloxacin or levofloxacin are highly effective, often in just a 3-day regimen, too.
Fluoroquinolones, okay. Why aren't they first line then?
Mainly because of concerns about side effects and growing resistance. The FDA has issued warnings about serious adverse effects like tendinitis, tendon rupture that's a black box warning, CNS effects, and others. Plus, we really want to preserve fluoroquinolones for more serious infections when possible. So they're alternatives used cautiously when other options aren't suitable.
Makes sense. Preserve the big guns. What about beta-lactams, like amoxicillin clavulanate?
Beta-lactams, like amoxicillin clavulanate or cephalexin, can be used, but they're generally considered less effective for acute cystitis compared to the first-line agents or fluoroquinolones. And a specific point. Plain amoxicillin or ampicillin are generally not recommended for empiric treatment because so many E. coli are resistant now due to beta-lactamases. You'd only use them if a culture specifically shows susceptibility, maybe for an enterococcus infection.
Got it. Beta-lactams are further down the list. Now, you mentioned 3 days for TMPSMX or fluoroquinolones, 5 days for nitrofurantoin. Is short-course therapy always the way to go for cystitis?
Another key point. That short course, like 3 days, is really only appropriate for uncomplicated lower UTIs.
Only uncomplicated.
Right. If a woman has a history of UTIs with resistant bugs, or if she's had symptoms for a week or more, or if it's a complicated UTI or any male UTI, short course is not enough. These patients typically need at least 7 days of therapy, maybe longer.
7 days or more for those trickier cases. Good distinction. And quick aside, things like cranberry juice, drinking lots of water, do they help treat an active infection?
You hear that a lot, right? But currently, there's no proven benefit for things like ibuprofen, increased fluids, cranberry products, or acupuncture for treating an acute cystitis episode. They don't replace antibiotics for an active infection.
Okay, focus on the antibiotics. Let's test this. Here's a quick practice question for you listening. A 28-year-old woman presents with dysuria and urgency. Her urinalysis is positive for leukocyte esterase and nitrites. What is the most appropriate empiric treatment? A, cephalexin, B, nitropfurantoin C, ciprofloxacin D, amoxicillin. What do you think?
Okay, looking at those options. Classic uncomplicated cystitis presentation, positive urinalysis. The most appropriate choice there is B, nitropfurantoin. It's a first-line agent. Cephalexin and ciprofloxacin are alternatives, and amoxicillin is generally not recommended empirically.
Perfect. B, nitrofurantoin. Okay, so that covers uncomplicated cystitis. Now let's move up the urinary tract to pyelonephritis. This is more serious, right?
Much more serious. Pyelonephritis means the infection has reached the kidney tissue. It's a tissue-invasive disease.
Tissue invasive. So the approach has to be different.
Completely different. First, you need a broader initial empiric antibiotic regimen because you have to cover the likely pathogens effectively and quickly. Second, treatment duration is longer, at least 7 days, often 10 to 14 days. And third, urine culture and susceptibility testing are absolutely essential here. You need that culture to guide therapy.
Essential culture.
Yeah.
Okay. What are the treatment options for pyelonephritis? Maybe starting with someone stable enough to be treated outpatient.
For uncomplicated pyelonephritis managed outpatient, oral ciprofloxacin for 7 days is often preferred if local fluoroquinolone resistance rates are low, meaning 10% or less.
Cipro only if resistance is low. What if resistance is higher or Cipro isn't an option?
Then TMPSMX for 10 to 14 days can be effective if the bug is known to be susceptible. Now, here's a really important point for outpatient pyelo. If the susceptibility isn't known yet, or if you're worried about resistance, it's recommended to give an initial intravenous dose of a long-acting drug before starting the oral outpatient therapy.
Initial IV dose first, like what?
Like a one-time IV dose of ceftriaxone or ertapenem, or even a long-acting aminoglycoside like gentamicin or tobramycin. This helps ensure you get adequate drug levels quickly while waiting for culture results or for the oral meds to kick in.
That makes sense. Hit it hard up front. Are oral beta-lactams okay for outpatient pyelo?
Generally, oral beta-lactams are not recommended as first-line empiric therapy for pyelonephritis. Their efficacy rates tend to be lower compared to fluoroquinolones or TMPSMX in this setting.
Okay, no oral beta-lactams first line. What about patients who are sick enough to be admitted? Complicated pyelonephritis needing inpatient care.
For complicated pyelonephritis requiring hospitalization, the primary therapy is usually intravenous. You'd use broad-spectrum IV beta-lactams like ceftriaxone or maybe ertapenem if you need carbapenem coverage, aiming for good coverage against E. coli and other common gram-negative bacilli.
IV therapy initially. How long do they stay on IV?
Until they're clinically improving and able to tolerate oral medications. Then they can transition or step down to oral therapy to complete the treatment course, usually for a total duration of 10 to 14 days, sometimes longer, depending on the severity and the pathogen.
Okay, step-down therapy. Let's do another practice question focusing on these serious infections. A 45-year-old woman comes to the ER with fever, flank pain, nausea, looks like acute pyelonephritis. Local fluoroquinolone resistance is 15%. Which initial IV agent is recommended if oral therapy isn't feasible right away and susceptibility is unknown? A. NIT rofurantoin. B. Oral ciprofloxacin. C. Ceftriaxone. D. Amoxicillin.
All right, let's break that down. Pyelonephritis needs IV initially. Fluoroquinolone resistance is high at 15%. Nitrofurantoin, A, is out never for pyelo. Oral Cipro B isn't appropriate given the resistance and need for initial IV. Amoxicillin D isn't recommended empirically. That leaves C, ceftriaxone. That initial IV dose of ceftriaxone, ertapenem, or an aminoglycoside is exactly what's recommended here. So C is the answer.
C. Ceftriaxone. Makes perfect sense. Now, shifting slightly, what about those generally complicated UTIs, not necessarily pyelo, and specifically male UTIs, including prostatitis? How do we approach those?
For complicated UTIs in general, maybe due to a structural issue or instrumentation, the initial empiric coverage often needs to be even broader than for uncomplicated pyelo. You might consider drugs like cefepime or piperacillin tazobactam, or even a carbapenem like meropenem or imipenem cilistatin if you suspect highly resistant organisms like ESBL producers.
So potentially bigger guns right from the start.
Yes, depending on the patient's history, local resistance patterns, and severity. For therapy duration depends on how sick they are, and again, culture results are key to narrow things down later. Total treatment is often up to 14 days.
And males. You said they're almost always considered complicated. What's the focus there, especially with prostatitis?
Right. Male UTIs often involve the prostate. Prostatitis is inflammation of the prostate gland, usually due to infection. It can be acute, with sudden fever, tenderness, urinary symptoms, or chronic, which is often a recurring infection that's harder to clear, presenting with maybe low back pain, perineal pressure, difficulty urinating.
Sounds unpleasant. What bugs cause it, and what's special about treating it?
Usually the same culprits, gram-negative enteric bugs, especially E. coli. The treatment goal is similar, kill the bacteria, but the key difference is drug penetration. You need an antibiotic that can actually get into the prostatic tissue at therapeutic concentrations.
Penetration to the prostate. Which drugs do that well?
The ones known for good prostatic penetration are primarily TMP-SMX and the fluoroquinolones. That's why they are often the first-line oral agents for prostatitis.
Okay, TMP-SMX and fluoroquinolones for prostate penetration. How long do you treat prostatitis?
Much longer than typical UTIs. For acute prostatitis, you need a total course of 4 to 6 weeks to really eradicate the infection and try to prevent it from becoming chronic. Chronic prostatitis might need 6 weeks or even longer. Sometimes, for recurrent chronic cases, long-term low-dose suppression therapy might even be considered.
4 to 6 weeks minimum. That's a long time. Okay, so we've covered picking the drug based on infection type and location, but we always have to think about the patient, especially their kidneys. What are the crucial renal considerations and maybe some major adverse effects we need to monitor?
Absolutely. Kidney function is critical for many of these drugs. We already hit NIT rofurantoin hard. Avoid if CRCL is less than 30 ml/m, period.
Got it. CRCL 30, no nitrofurantoin.
TMP-SMX and fluoroquinolones like ciprofloxacin and levofloxacin usually do require dose adjustments based on renal function, so you need to calculate the patient's CRCL and adjust the dose accordingly.
Dose adjusts TMP-SMX and fluoroquinolones. What about aminoglycosides? Gentamicin, tobramycin?
Aminoglycosides achieve good urine concentrations, which is helpful, but they are renally excreted and have that narrow therapeutic window. This means you must do therapeutic drug monitoring, checking serum drug levels, along with kidney function markers like serum creatinine and BUN very closely, and you have to watch carefully for their main toxicities: nephrotoxicity, kidney damage, and ototoxicity, hearing or balance problems.
Close monitoring needed for aminoglycosides. Okay, beyond renal issues, what are some other significant side effects pharmacists really need counsel patients on or watch out for?
Definitely. Let's run through the main ones. For TMPSMX, rash is common, but watch for severe forms like Stevens-Johnson syndrome. Also renal failure, photosensitivity, hyperkalemia, especially important in the elderly, and potential blood count issues like neutropenia or anemia. Monitoring involves kidney function, electrolytes, and CBC.
Hyperkalemia in the elderly with TMPSMX, that's a good pearl. What about fluoroquinolones?
Fluoroquinolones. Besides hypersensitivity and photosensitivity, GI upset, dizziness, confusion are possible. And that big one, the black box warning for tendinitis and tendon rupture, always counsel on that risk. Monitor baseline renal function and CBC.
Tendon rupture risk. Okay. Nitrofurantoin.
Nitrofurantoin. GI upset is common. Less common but serious are neuropathies and pulmonary reactions. Again, monitor baseline renal function.
And fosfomycin.
Fosfomycin is generally well tolerated. Main things are maybe diarrhea, headache, rarely angioedema. No routine lab monitoring is usually needed.
And the beta-lactams is a class. Penicillins, cephalosporins.
Beta-lactams. The big one is hypersensitivity rash all the way to anaphylaxis. Diarrhea is also common. Some, particularly cephalosporins and carbapenems, can lower the seizure threshold, especially in renal impairment. Always monitor for signs of allergy.
Great overview of risks. Let's do a couple more practice questions based on that. First, renal function again. Which agent should be avoided in a patient with CRCL of 25 millimin? A, TMPSMX, B, fosfomycin C, NIT-Rofure, Antoine D, ceftriaxone.
We've hit this one a few times. CRCL of 25 is below the 30 mmmin cutoff for C, NIT, Rofure, and Toin. Definitely avoid it. The others might need adjustment or are generally safe renally.
Correct. C, nitrofurantoin. Now, focusing on side effects. Which adverse effect is most associated with TMPSMX in elderly patients? A, QT prolongation, B, hyperkalemia C, nephrolithiasis, D, rash only.
We just mentioned this pearl. While rash can occur, the most notable risk, particularly highlighted in the elderly for TMPSMX, is B, hyperkalemia. It's due to its effect on potassium handling in the kidneys.
Perfect. B, hyperkalemia. Okay, we've covered a lot of ground. Let's touch on a few special patient populations that always seem to have unique rules.
Yes, definitely need to cover pediatrics, pregnancy, and catheterized patients specifically.
Let's start with kids. UTIs and pediatrics.
In kids, prevalence changes with age and gender, more common in young boys initially, then flips to girls. A key challenge is that very young children often don't have specific urinary symptoms, making diagnosis tricky. A urine culture is often necessary.
What about treatment for kids?
Oral options often include TMPSMX or a cephalosporin like cephalexin. Treatment is usually longer than adult uncomplicated cystitis, maybe 7 to 14 days. And the big warning, fluoroquinolones are generally not recommended for kids under 18 due to concerns about musculoskeletal development like cartilage issues.
No fluoroquinolones for kids under 18. Got it. Next, pregnant women. This seems high stakes.
Extremely high stakes. The goal is zero bacteriuria throughout pregnancy because untreated UTIs, even ASB, can lead to serious complications, premature delivery, low birth weight, even stillbirth.
So screening is important.
Crucial. Screen with a urine culture at least once early in pregnancy, maybe 12, 16 weeks, or the first prenatal visit. And here's the vital point. Treat all positive urine cultures, even if it's asymptomatic bacteriuria, ASB.
Treat ASB in pregnancy, always. What drugs are safe?
Safe options generally include amoxicillin clavulanate, cephalexin, nitrofurantoin, and sulfonamides, but avoid sulfonamides near term. Treatment is usually for 7 days, and follow-up cultures are needed to confirm eradication.
Okay, and what absolutely must be avoided in pregnancy?
Avoid tetracyclines, they're teratogenic. Avoid fluoroquinolones due to risks to fetal bone and cartilage development. Avoid sulfonamides near term due to risk of kernicterus in the newborn. And avoid nitrofurantoin right at term, 38 to 42 weeks, or during labor delivery due to risk of hemolytic anemia in the baby. Also avoid if nursing an infant under 1 month.
Lots to remember for pregnancy. Lastly, catheterized patients again. We know not to treat ASB, but what if they do become symptomatic?
Right. Catheter-associated UTIs, CIUTIs, are super common, about 80% of hospital-acquired UTIs. If a patient with a catheter develops symptoms, fever, flank pain, altered mental status, you suspect a CIUTI.
So what's the first step?
Before even starting antibiotics, if the catheter has been in place for a while, the recommendation is to remove the catheter and, if still needed, replace it with a new one before collecting a urine sample for culture and starting treatment.
Remove and replace before treatment. Why?
Because the old catheter is often colonized with biofilm, a slimy layer of bacteria. Treating with the old catheter in place makes eradication much harder and increases the risk of complications like pyelonephritis or bacteremia. Get rid of the source first.
Get rid of the biofilm source. Makes sense. That reinforces our earlier point.
Exactly. If there's a cath, cover wide and pull early, or at least remove and replace before treating.
Okay, great summary of special populations. To help cement all this, let's quickly run through those mnemonics and key pearls again.
Sounds good. Mnemonics first. For uncomplicated cystitis, remember nitro and Bactrim for bladder bugs.
Nitro and Bactrim for bladder bugs.
For that single dose option, fosfomycin, 1 dose equals 1 flush fix.
1 dose, 1 flush fix.
Got it. For the kidney infection, Pilo, high air, treat high up, IV or fluoroquinolone. Think systemic treatment.
Treat high up.
And for catheters, if there's a cath, cover wide and pull early or remove a place before treating symptomatic infection.
Pull early. Excellent. And the absolute key takeaways.
Okay, rapid fire. UTIs equals cystitis lower versus pyelonephritis upper. E. coli is king, 70 to 95%. First line for uncomplicated cystitis, TMPSMX, nitrofurantoin, fosfomycin. First line options for pyelocomplicated. Fluoroquinolones, TMPSMX, IV beta-lactams, often with initial IV dose.
That's toothpaste. Keep going.
Short course, 3 days, is only for uncomplicated lower UTIs. Longer courses, 7 days for complicated male or pyelo. Fluoroquinolones are generally not first choice for uncomplicated cystitis, resistant side effects. Non-drug therapies don't treat active cystitis. Pregnant women, screen and treat all positive cultures, including ASB. Symptomatic CA-UTI, remove or replace catheter before treatment.
Fantastic summary. You just reviewed the core management strategies for UTIs, uncomplicated, complicated, and everything in between. You really do have the tools now to assess, treat, and adjust like a pro. Think back to those initial questions: sulfa allergy, low CRCL, the man with flank pain. You should feel much more confident navigating those now. Next deep dive: sepsis and bloodstream infections, where timing and targeting are absolutely everything. Until then, keep learning and keep pushing forward.